So good afternoon everyone. Welcome to the 9th episode of the Genomics Gupshup. This is where we talk to experts in different fields in genomics and in allied subjects to be able to build the trust that is required between clinicians, geneticists, genetic counselors and the community in general. Today we are excited that we have someone so eminent like Dr. Sonia Rani, who is one of Hyderabad's best obstetrician and gynecologist, but also is a specialist in fetal medicine. So I'm very, very excited to have you here. Welcome, Dr. Sonia.
Yeah, thank you. Thank you so much. Namaste. I'm very much happy that I'm here in Mapmygenome Institute today. Recently, many genetic institutes have come up, but with genomics as a background, genetics as a vast subject, it is very essential that we need to have some idea about what genetics is and how it is applicable in our current scenario. So we see many abnormal babies, we see many couples striving a lot to have a normal baby in spite of many pregnancies. So here it comes wherein the knowledge of genetics is essential. So very nice of you that you are arranging this introductory events with some of the genetic specialists, and I hope you will have many such events in the future.
Thank you, Dr. Sonia. So before we get on to the genomics and genetics and all, what inspired or who inspired you to become a medical doctor, and then why fetal medicine? Can you help us go through your journey a little bit?
Yeah. So I am in a family of 4 sisters, and most of our family members and sisters are all farmers. So we hail from a village family. My father was a doctor who did his masters, MBBS and all in Vizag, Visakhapatnam, King George Hospital, and since childhood I was there with him. After school I was there. I used to spend most of the time in the hospitals. I used to see the suffering of the patients, and some patients who are very much satisfied after the treatment, the immense satisfaction which a consultant or a clinician gets after a patient is cured of his disease. This might be the most motivating factor for me to become a doctor. Though many people told me if you take the engineering stream you would settle soon, you would have an early settlement, you would financially also you will be better. In spite of 4 girls in our family, eldest one, this inspired me to become a doctor.
That's fantastic.
Yeah.
So you've also done a lot of, like you did your MBBS, then you did a postgraduate, and then you have a whole series of diplomas from London, from Germany and others. One thing that really struck me was you had a diploma in art and the reproductive medicine.
Yes.
So what exactly does that mean? Does it mean reproductive medicine is an art, or what exactly is that?
Actually, yes, that is a diploma in ART and reproductive medicine. It is not art, it is ART, Artificial Reproductive Techniques.
Okay. not art and science.
No,
Okay. Yeah.
Not art as such. It is Artificial Reproductive Techniques. So every now and then, other than my basic MBBS education, I went into my Obstetrics and Gynecology stream, and I used to deal mainly with high risk obstetrics along with the basic obstetrics and gynecology. So in further advancement in this field, there are many other subspecialties, like it's not subspecialty, it would be super specialty, like laparoscopy in gynecology and obstetrics, and dealing with high risk pregnancy care, dealing with the fetus as a patient, that is fetal medicine, dealing with genetic aspects of parents and the fetus, that is again genetic specialty, and further advancement would be reproductive techniques. Previously we used to know only about IVF, ICSI pregnancies. Now there is some genetic aspect in reproductive techniques also, that is pre-implantation genetic diagnosis of a particular known disease or pre-implantation genetic screening. So even in reproductive techniques also we have the genetic aspects. So from the basics to advanced gynecology and obstetrics, we can say that these super specialties are still having their good role. So from basics to advanced.
So I'll get back to the art, right? So do you think it is all science, or do you think that talking to patients also needs a little bit of an understanding or an art in some form?
Yes, that is very much needed.
Yeah.
Very much needed. It's not like we apply whatever we study in our clinics. The interaction with the patient is very much essential. How we receive them, how do we listen to their problems, and how do we go about dealing with their problems, and what best we can give out to them for their problems. That would be what is much expected of them. So that is very important, what I feel. Patient counselling, making them understand what the problem is, what are the solutions, what we can do, what cannot be done. So what are the financial aspects of it. So these are the important things which whether they can be done or not done, we should discuss with the patients first. So then we get their consent and their willingness. That is how we can help the patients.
So you lay out all the options for them.
Yes. We give all the basket of options to them, and patient, it's finally their call to decide
what they do.
Yes.
So I saw a video of yours which basically talked about getting to more normal deliveries. In the time when I think a lot more cesarean deliveries are going on, why do you strive to do that?
Yeah, this is a good question. So basically we come from a normal delivery. Previously they were all normal deliveries, and cesareans were very less few decades back. Now cesareans are high, and in Telangana it seems we are doing the highest number of cesareans here. Recently the government has also been issuing notices to most of the obstetricians and gynecologists. Going way back to our decades, few years back, it is essential that we need to do normal deliveries again. We are doing, but still most of the gynecologists should be motivated to have some patience to treat. Even the patients are nowadays not so much motivational towards having normal delivery. This motivation for normal delivery doesn't start at the time of delivery. It starts from the beginning of pregnancy, confirmation of pregnancy onwards. So that is how throughout the 9 months we tell them what things to be done, what not to be done. Encourage them more towards a normal delivery. And we should stop the pampering from their parents. So the pain tolerance, different kinds of exercises which they should do, and different kinds of the food which we get now and the food few decades back is also different. So certain food restrictions also should be there, and the prenatal yoga, motivation from birth assistants, that is also important. The prenatal yoga will help much. So these are the important things. It's an all-round environment that should be favorable for the women to have a normal delivery. Family members support, the institutional support from the hospital consultant and the staff is also very much essential. Not just the clinician motivating the patient. It's an all-round wholesome support, I feel.
Yeah, the family and everybody else should.
That is very, very important.
So I think when they come to see a doctor like you, do people come to you? I mean, do large majority, I can't say, I'm sure there's no generalization, but do a large majority of you come to you 6 months before they plan on a baby, or do they come after they've had after they've conceived? Or when do people come? People come to a fetal medicine specialist? Maybe if you can help us understand a little bit of.
So this varies in different parts of the country. In rural areas, the awareness is less, so they don't see the consultant until they are 3 months of their pregnancy. Whereas in urban areas, cities like this high metropolitan cities, they do come for a preconception counselling that starts 3 to 6 months before planning pregnancy. Most of the couple come 6 months ahead for before planning pregnancy, wherein we advise them certain important blood tests. We assess their medical conditions, previous surgical conditions, personal history, and any family history of any genetic problems. So this 6 months of period, it will give us some advantage to diagnose and see her preparedness for a pregnancy, to bring out a healthy mother and baby. So in rural areas that is not the case. Even past 12 weeks of pregnancy, 14 weeks of pregnancy, they don't come to the clinician because it is the taboo in their house that until 3 months you should not go to the doctor. So what the elders say, that is the same is being followed. So that is the difference in cities and rural areas.
So do you think that if money was in a constraint, would you think that doing a carrier screening, a genetic carrier screening, is something that to-be parents should be doing in terms of understanding their what kind of potential mutations they have? Is that something that is one, whether you advise it, and two, whether patients like it? That is, both of them are potential places where.
Yes. So here, financial constraint is one of the important thing, and first of all, the patient should understand whether it helps them or not. If there is any family history again of any genetic disorders, even before they plan for marriage, that is prenuptial counselling we say. Here comes, especially in consanguineous couples, there is definite role of genomic testing, gene sequencing, which helps in preventing many abnormal babies, all recessive genes accumulating in one generation, and that is expressing as the next generation. So this comes as premarital counselling also. So here comes the importance of genetic counselling definitely, and genomic sequencing especially it helps there.
So I remember there is an app that had come up in the US. I don't know whether you've come across that or not, but basically it was to look at the carrier screening for potential parents to be, and it was more for dating. So now,
so that is all selective things.
So basically, you select that if you upload your all these carrier status, if there is a potential possibility, then you did decide not to go ahead with that.
Because in those countries they know their genetic status already. Certain genes like cystic hygroma genes and certain important major recessive genes, which they have already from their parents or diagnosis at birth. This would definitely help, and the patient knows their genomic map actually. They know their genetic disorders prior to their planning for pregnancy or prior to their planning for marriage. So two couples having in a couple, if both have the same disorder, better they can avoid that. So yes, that helps very much. I don't think in India it's
we are seeing a lot. Yes. I mean, some people are coming to us. We have a product called Mapmygenome where we match them.
Yes.
And the whole
that will help a lot actually.
The concept of doing a genome patri, we said you don't match your genome patri, you match your genome patri, right? Yes. So that is what we were thinking, but it's slowly starting to increase. But I think we need a lot more awareness.
Awareness is very much essential.
So one of the other things that we often see, both in terms of understanding genetic risk and others, is PCOS, and that's fairly common amongst women. So do you think that that's something that affects their possibilities of getting pregnant, or how? I mean, is there any correlation that is there? Or
PCOS definitely affects fertility, especially. So PCOS is polycystic ovaries is not a single gene etiology. It is multigenic and it is multifactorial. So environmental factors also do have effect on the kind of PCOS or the age at onset of the polycystic ovaries. So when it comes to the fertility aspects, it is much affected. We have seen adolescent girls with PCOS and also 40-50-year-old with polycystic ovaries. Yes. So adolescent girls do express it very soon because of irregular cycles, menstrual disturbances, prolonged periods of amenorrhea. So if we modify their lifestyle at that earlier stage, that would help them a lot in preventing the future fertility related issues. And later on, it is the metabolic syndrome, which is very dreaded situation next after fertility. So polycystic ovaries causes fertility issues, ovulation problems, and lack of good quality eggs, hence ovulation problems, and miscarriages also, and gestational diabetes. And later on, metabolic syndrome, wherein diabetes, hypertension, and stroke, and later endometrial cancers also can occur in women with polycystic ovaries. So the modifiable risk factors like lifestyle changes can be done at least. If not the genetic factors which cannot be modified, at least the environmental factors like lifestyle modification can be done to overcome certain problems. That would definitely help.
So the sooner they find out, it's better.
Yes. And it is almost 13 to 20% of women we see with polycystic ovaries.
Wow. That's a lot of...
And every 10 women who walk into the clinics, 8 to 9 of them are having polycystic ovaries and its related issues.
So that's a significant number.
Yes.
And maybe we should create awareness in schools then, because that's the time when maybe if we have to do it earlier, then maybe doing that. Some sort of screening up ahead.
It's very important. Just like anemia screening, we may have to have polycystic ovary screening also.
I didn't realize it was that high. I knew it was high.
It has become an epidemic kind of now.
So when did you first start using genetic tests? And I guess there are many types of genetic tests, right? So there is you obviously have those double marker, quadruple marker,
double, triple, and quadruple markers. Right from my practice onwards, I did my MBBS in Osmania, and post-graduation was from Kakatiya Medical College. That is a government hospital in Warangal. So there the private clinicians used to do. In government setup, it was not possible to do the double marker test. So it was only the ultrasound which was available then, way back 12 years. Then since then, it's been 12 years that we have been seeing and using double markers and triple markers. Triple marker is outdated now. Where in first trimester we do the double marker test, and in second trimester we do the quadruple marker screening. Now here in Hyderabad we do first trimester quad test, where we have advanced assessment of preeclampsia screening and prognosticating fetal growth problems and fetal preterm deliveries. These are the issues which can diagnose as early as 12 weeks. And we can have risk modification with echo screen also.
Okay. So basically, the sooner you do these tests, one, you can understand some of them which are genetic risks, but also other risks.
Yes, genetic factors, and also placental issues also we can modify. Certain things can be modified.
I think that's the key part. And I think if people realize that these are all things that are actionable in some sense, then they're able to do it.
There are still some people who don't advise double marker test even now, and don't advise a nuchal translucency scan even now. Still awareness, a lot of awareness is needed.
So I guess that's something that hopefully will build over a period of time.
Yes.
So how important do you think is genetic counselling? Or clearly you lay out the options for patients as well, but in terms of just helping them understand recessive or different kinds of understanding why this happens. Do you think that genetic counselling is a key element in terms of differentiating
different problems in the baby? Yeah, genetic counselling is very important, especially when coming to different genetic disorders which are very common, and those rare disorders we do try to counsel them by doing the genome sequencing and all those things. And starting from double marker test onwards, which starts at 12 weeks onwards, there itself we start counseling them about different chromosomal problems. First of all, they are not aware of what chromosomes is, so we start telling them, putting them on a paper, this we have 23 pairs of chromosomes, so there can some structural problems can happen, so mismatch, some genetic material can be missing. So we try to explain them in their own language so that they can understand, and they can tell their friends also. So someone will be telling, I had an nuchal transfer, NT scan, I had a double marker test, did you have the same? So that is how educating a patient will help herself and her friends and her family members also. Regarding genetics, it was not that that awareness was not there previously, but I think most of the people are aware now. So definitely.
You are in Kodapur, so I'm assuming a lot of the people who come are from the IT industry as well.
Yes. But still there are people among IT also who are not aware of it. Whoever it comes, we do explain the things.
So one more thing you had mentioned during your initial introduction, that you use laparoscopic
techniques. Yes, in obstetrics and gynecology.
So maybe you can help understand what exactly is a laparoscopic technique and how does it help?
Laparoscopy is a minimally invasive surgical technique. Most of us are aware of cesarean sections wherein we give 10 to 15 centimeters of incision over the abdomen, and in laparoscopy it is no scar kind of technique, wherein the size of the incision is less than 1 centimeter. It is 5 millimeters, 7 millimeter incisions, wherein there is no stitch, even stitch is also not applied. We usually use this in gynec setup, mostly for gynec surgeries, for ovarian cysts, polycystic ovaries, to diagnose any fertility related issues and any emergencies in gynec, especially tubal pregnancies like ectopics, wherein there is rupture of the tube, pregnancies in unwanted location. So to diagnose any abdominal pathology. So this is all a minimally invasive technique. We have been using it since many years. It's been more than 2 decades that we are using. But it has been more used nowadays, and there are advanced technologies with this also. In obstetrics, we do use laparoscopy if there is any obstetric emergency like ovarian torsion or any abdominal pathology only during the 2nd trimester of pregnancy. So that is when we use. And we do use laparoscopy for abdominal cerclage, wherein the women have repeated miscarriages and cervical cerclage is not beneficial to her. So we apply an abdominal cerclage through a laparoscopic technique. So that is how.
I'm sure you see a lot of difficult cases, right? But can you talk about any case where you use genetics and it was a challenging case to begin with?
Yeah. Couple of cases are there where we see abnormal babies, especially the fetal high drops, wherein the body of the baby accumulates lots of fluid, and all the tests have come out to be normal. The immune and non-immune etiologies have been ruled out. Still, the couple experiencing repeated losses of the babies. So I have sent for the entire genome sequencing also. Even the sequencing has come out to be normal, and it has brought out many variants of unknown significance also. So, but I could manage one couple with high drops of unknown etiology, wherein she has some autoimmune pathology by giving some immunosuppressants, and finally they have a baby now. So we don't know the etiology, but still they have got a 3rd baby after having 2 mishaps.
So these, what doctor was just mentioning, the ones, the variants of unknown significance are the ones where we find a mutation, but we have not yet necessarily
we don't know the clinical significance of it, what phenotype does it cause, but many unknown significant variants can be seen in genomic testing.
And the ones that are more clear cause of a problem, we call those as pathogenic.
Yes, pathogenic variants.
Yeah, I think that's hopefully in the next few years, I think many of the variants of unknown significance will be classified as a clear.
Some study has to be done on them. Their clinical significance has to be known.
So when you look at people with high risk pregnancy, or let's say somebody above the age of 30-35, they first do some sort of screening mechanism, that you do a double marker, quadruple marker, you do some scans, and how do you confirm these with some tests as well, right? Like an amniocentesis or something.
Yes.
So is that the right order in which I'm explaining, or is there usually a flow, or it depends?
Yeah, so when coming to the blood investigations to screen and diagnose the genetic issues, mostly we start with double marker screen, then we do first trimester quad screen. Either of these, patients can opt either of this. If the double marker screen has to be positive, and we do an early TIFA scan, so that will be scheduled at 16 to 17 weeks. If not, if we can do a chorionic villus biopsy also, if there is any early structural deformity that has been identified, this can be done at 12 weeks. If not, if the baby is structurally normal, we go with an early TIFA scan that is done at 16 to 17 weeks. And at 17 weeks, we can take a decision to do amniocentesis if there is any structural problem in the baby. The structural problem, as per the system wise, we advise for either karyotyping and fish if we want to know only the basic 3 chromosomal problems, that in 13, 18 and 21. If there is any pertaining structural problem, then we may advise for chromosomal microarray to detect the deletions and duplications. And if there is a panel of particular system, if there is a skeletal problem, if there is a cardiac system involvement, neurological system is difficult to diagnose at that particular age. If there is renal system involvement, a panel of genes can be advised. Or if we know a target gene, if a previous sibling is affected and that target gene is known to us, it would be a target genes based amniocentesis test.
That can be done.
Yes. So this is how it goes. If the double marker screen is missed by chance, then we advise for quadruple marker screening, which can be done from 15 to 22 weeks of age. This is how. Even non-invasive prenatal test is also there, which is very much used nowadays in women more than 35 years of age, certain IVF pregnancies, wherein the fetal component of the maternal blood should be at least 4%. It is a non-invasive test. We don't need to go near the baby, but it is still a screening test with 99% accuracy. It is very much near to amniocentesis, but still we say it is a screening test because false positives also can be there. Nothing is 100% sure.
But that's true of most things in life,
yes,
right?
Yes. None is 100% sure. So amniocentesis is an invasive procedure, so we need to counsel the patient, we need to take their consent, we need to explain the problems that may be there with amniocentesis, the advantages with amniocentesis, and then go ahead with the procedure.
So I think someone needing to see the workflow of events. So a lot of things I think you have to take care of your patients in quite a lot of detail.
We make them go through all this terminology, we explain all the things. After that only we give them the choice, like it's their call, whatever they opt, they will get it done.
And do you see that there is, how do you identify preeclampsia risk in women as well, and which one of these many tests that you mentioned?
So preeclampsia risk can be identified as early as 12 weeks in the nuchal translucency scan. After the nuchal translucency scan is done, in the ultrasound we check for the uterine artery Dopplers, wherein the mean Doppler, there is a particular number for the mean of the uterine artery pulsatility index. So if it crosses that particular number, we usually wait for the double marker report. In double marker report, it is the beta HCG and placenta PAPA. So pregnancy associated placental protein. So this is one important marker which tells about the risk of preeclampsia and also fetal growth, and subsequently there will be fetal growth issues also. PAPA should not be less than 0.5 moms as per a standard analyzer, as per a standard gene analyzer. So if the PAPA is less than 0.5 moms and the uterine artery pulsatility index is more than 1.2 mean pulsatility index, these are the standard cutoffs which we as obstetricians usually use. Then we advise the couple of the risks of having a preeclampsia, that is a pregnancy and high blood pressure related problems and placental problems especially, and placental perfusion problems, so subsequent fetal growth related issues and low birth weight babies and low amniotic fluid babies. So these are the subsequent things which we can predict as early as 12 weeks. This might happen after 28th week, but we can predict as early as 12th week, and supplementing the women with ecosprin, which is a very wonder drug to say for us as obstetricians, or 150 mg of ecosprin daily given once a day till 36 weeks at least, might help to avoid certain problems to some extent. It is not, it completely blocks the seam, but so it's not a game changer, but still it helps. We have seen many pregnancies going into that poorer prognosis of the baby. Many babies we have seen which have done very well with ecosprin alone. So that is, ecosprin is still very cost effective, doesn't cost much. So a very early intervention which helps in bringing out a good baby.
So I'm sure that you come across so many different difficult, challenging problems. But in the end of the day, I think having given birth to a baby for help couples have a baby. I think there can't be anything more exciting than that.
Yes. After all these things, after this 9 months, see, first of all, they come to us whether we are prepared for the pregnancy or not, doctor. We don't know. Please help us. They start with that 6 months prior to planning pregnancy. So they start from there. Then throughout the 9 months, each and every day is a challenging task for them. Not every couple will be as easy as we see. There are couples who face each day as a challenge. Every day will be a challenge for them. So 6 months prior to planning pregnancy, 9 months of entire duration of pregnancy, during delivery and parenting. So this is how complete parenting goes. Definitely.
So are there any movies? I think in movies they mostly show just people having morning sickness, and that's pregnancy, right? I think maybe there should be more movies which can educate us on, actually understanding, what goes on actually, because not everybody has just, some people don't even have morning sickness, but some people have this thing, and then many people have a much more difficult time than others.
Yes. So morning sickness can lead to hyperemesis, excess vomiting. There are people who have admitted in ICUs with excess vomiting and all. Every pregnant lady can make a biopic of her during her pregnancy and then she can use it. So use it to train others or maybe to help others. So because each pregnancy is different. Even a single mom having 2 different pregnancies, she might have 2 different experiences.
Absolutely.
Yeah, that's how.
So I think that brings me to, I won't ask you any more difficult medical questions now. I'll come to the more fun and the light part of our conversation. I think, one, it has been absolutely incredibly helpful. I think a lot of people who will be watching this will be, people who are looking at maybe having a baby or otherwise. I think that really helps them in understanding that better. But, while you're doing so many different things, let's start off with, do you have a hobby?
Yeah, I have a hobby. So I was into sports mostly in childhood. I was an athlete. So I used to 10 different sports. So now I'm with different degrees to say, not with sports now. So now mostly my hobbies is just to find some peaceful time and just to sit in some peaceful place with greenery. That is just the best hobby I think I should say now in the city, in this busy life and all.
So we don't
yes, we don't find such a place. At home I do lots of gardening. So inside my home also I have lots of green small plants and all.
And you cook food from nature?
Yeah, I'm not a good.
No, I thought you plant your trees and
most of this are just interior plants like that. So morning when I get up, I love to see the greenery and all, and I feel happy. I just grow them as some living beings only. That is how.
That's great. And do you have a favorite book or a movie?
Yeah, movies are there. Not the current movies. Most of the time I go for the Western movies. Yeah. So in that, in the pursuit of happiness, that is the one of the movies which I can say. So there is a constant effort to do something. So I usually have that constant efforts towards whatever I want to achieve. So that drives me already. I don't need somebody else to push me to something. So my brain tells me what to do. That's it. So it's my inherent gut feeling that I have. That's it.
And is there a favorite city or town that, since you said you like to go to a quiet green place?
Yes, obviously. A less polluted country with much of greenery, wherein we have very few countries like that. Poland, Germany, Italy, so UK. I didn't cross India till now. I don't have plans to cross also, but I prefer India to become like that, less polluted, more greener, more environmental friendly. So each of us should have that awareness to save the planet.
to grow
Finally.
plants also.
Yes. Finally, we should save our planet.
Harisha Haram.
Yes.
Yeah.
Telangana to Harita.
Yeah.
Government is also striving a lot to have lots of greenery. So
That's fantastic. So, is there anything else, last words of advice for either young students who are getting into becoming a fetal medicine specialist or a geneticist, or anything that you would like to share with?
yeah, definitely. So obstetrics and gynecology is not a dead end. So you have further super specialties also, wherein you can have your basic obstetric practice, but still you need to be more advanced in your further super specialties. That is what I say. If you choose a fetal medicine, you should be more specific in that, how you are able to choose that specialty, why did you choose, what advantages do you have in choosing that, how good you are, how effective you are in that. And always choose what your passion says. It's not like somebody else should come and say. You choose what, we usually should choose what we need, that's it. I enjoy my fetal medicine specialty. Every time I see a baby, I feel very happy. That I think that's what drives me to do more of studies in that. To continue in the same specialty.
So you still are taking more courses, or?
Advances. We have to be updated, right? We go for further conferences and all. So every time I see a baby, it gives me immense happiness.
That's
along with the parents. That's what drives me so much.
Great.
Yeah.
So, thank you so very much. It has been an absolute pleasure and honor to have you here. And I hope that you continuing in your pursuit of making healthier babies for this country and planet. So thank you very much.
Thank you so much. Nice talking to you.